When drugs are the cause of organ morphogenesis errors like malformation, these drugs are called teratogens and are a commonly tested subject for step 1. As mentioned earlier, embryos are most susceptible to teratogens from week 3 to week 8 because this is when most organogenesis occurs. Some teratogens are actually more damaging before week 3, but damage caused at such an early stage is often fatal, so a malformed baby will never be born. After week 8, the growth and function of organs can still be affected by teratogens, but it is less severe and often reversible. Many of these teratogens are covered in other chapters, but this slide summarizes some of the most high-yield drugs and their effects. I won't read all of these to you, but I'll go through and point out some things. Alcohol is the most common cause of birth defects and mental retardation due to its widespread use. We'll cover fetal alcohol syndrome in depth in the next slide. Aminoglycosides causing cranial nerve 8 toxicity and cocaine causing placental abruption are also important to know. Lithium's cardiac effects and tetracycline's tooth discoloration are both frequently tested, so make sure you remember those. Thalidomide is one of the more infamous teratogens because it was widely prescribed in the late 1950s before anyone knew it was a teratogen, and over 10,000 babies were born with missing limbs before anyone figured out the cause. This led to stricter drug testing policies at the FDA starting in the 1960s. Excess vitamin A, such as what is found in the acne medication Accutane, is also teratogenic. And finally, you can remember that warfarin is a teratogen using the mnemonic warfarin declares war on the fetus. Alcohol is the leading cause of congenital malformations in the United States. The first thing you'll notice about someone with fetal alcohol syndrome is the facial abnormalities. These patients have small eyes with folds of skin at the nasal corners, a low nasal bridge, which makes their nose appear shorter, and a thin upper lip with no groove between the upper lip and the nose. They will also usually be small for their age due to prenatal and postnatal developmental retardation, and also have mild mental retardation and other neurological symptoms, such as hearing loss, poor eye-hand coordination, and epilepsy. Patients are at increased risk for holoprosencephaly, in which the forebrain of the embryo does not form two separate hemispheres. Heart and lung fistulas are more common as well. Statistically, babies born to mothers who consumed only 1 drink per day are at no increased risk for fetal alcohol syndrome, while alcoholics or heavy drinkers, such as those who consume 5 or more alcoholic beverages in one night, are at risk. It isn't completely understood how alcohol causes these symptoms, but it may have something to do with inhibition of cell migration. Okay, moving on to twinning. Do you remember which of the 5 types of errors in organ morphogenesis twins are at risk for? That would be deformation, since it can be crowded in the uterus and twins can put physical pressure on each other. The 2 types of twins are monozygotic, meaning they came from 1 embryo, 1 egg plus 1 sperm, and are genetically identical, and dizygotic, meaning they came from 2 separate embryos. In other words, 2 eggs fertilized by 2 separate sperm that were fertilized independently and are therefore genetically different. Dizygotic twins will each implant separately, have their own chorion and placenta, and their own amniotic sac. Monozygotic twins, however, can share some of these things depending on when the embryo divided into 2. In about 25% of cases, the embryo of monozygotic twins splits before the chorion is formed at day 3, and these embryos will have their own placentas, chorions, and amniotic sacs just like dizygotic twins. More commonly, about 75% of the time, the embryo splits between days 3 and 8, when the chorion has already formed but the amniotic sacs have not. These twins will share a chorion and placenta, but each will have its own amniotic sac. Very rarely, less than 1% of monozygotic twin embryos will split after the amnion forms. These twins are at risk for being conjoined, especially if the split occurs after the bilaminar disc forms at day 12. So we've mentioned the placenta a few times now, but what exactly is it and what does it do? The main function of the placenta is nutrient and gas exchange between the mother and the fetus. You can see the anatomy in this image. The fetus contributes the chorion to the placenta, and this includes the cytotrophoblast and syncytial trophoblast, which are the outer layers of the chorionic villi. The cytotrophoblasts, which are the entities that look like cells in this image, are kind of like the stem cells of the placenta. They can differentiate into syncytial trophoblasts or form more cytotrophoblasts as the placenta grows. Syncytial trophoblasts are the white layer outside of the cytotrophoblasts, shown here. And these cells actively invade the uterine wall and secrete HCG. As you may remember, HCG is the hormone pregnancy test measure and is secreted beginning at day 6. HCG is necessary during the first trimester to maintain the corpus luteum, which secretes progesterone. After the first trimester, the placenta takes over progesterone production and the corpus luteum degrades into the corpus albicans. The maternal contribution to the placenta is the decidua basalis, which comes from the endometrium. Maternal arteries and veins flow through it to supply blood to the placenta. Maternal blood pools in these large spaces called lacunae, which is Latin for little lakes, around the chorionic villi, and gases and nutrients diffuse between the mother and fetus. For blood to get from the placenta to the fetus, it travels through the umbilical cord. As is the case in the pulmonary circulation, the umbilical arteries have deoxygenated blood, and the veins have oxygenated blood. Remember, the artery-vein naming convention is in reference to the fetal heart, not the mother's heart. There is only one vein, which supplies blood to the fetus by draining into the IVC, and there are 2 arteries, which return deoxygenated blood from the internal iliac arteries. These vessels are supported by Worden's jelly, which is a gelatinous substance that contains many stem cells and is also made up of fibroblasts, macrophages, and mucopolysaccharides, such as hyaluronic acid and chondroitin sulfate. So how is the umbilical cord formed? It starts as an endodermal evagination from the developing hindgut called the allantois, which extends into the urogenital sinus during week 3. A mesodermal connecting stalk surrounds the allantois, and this is the early umbilical cord. The fetal bladder is connected to the allantois through the arachis, and nitrogenous waste is removed through these structures. Blood vessels from within the stalk connect the fetus to the placenta, and the allantois eventually regresses, leaving just the arteries, vein, and arachis in the umbilical cord. After birth, the urachus regresses as well, leaving a fibrous remnant known as the medial umbilical ligament. If the arachis remains open, this is known as a patent arachis, and urine continues to be discharged from the umbilicus after birth. It can also form a vesico-urachal diverticulum, which is an outpouching of the bladder, if it is mostly obliterated but the most proximal portion remains open. Another important structure for carrying nutrients to the embryo is the vitelline duct, which connects the yolk sac directly to the lumen of the midgut. This is normally obliterated during week 7, since the embryo is no longer receiving nutrients from the yolk sac, but sometimes abnormalities occur. If the duct does not close, the neonate will have a vitelline fistula, allowing meconium discharge from the umbilicus. Partial closure causes Meckel's diverticulum, which is an outpouching from the ileum that occurs in about 2% of the population and is generally asymptomatic, but can also cause symptoms such as rectal bleeding, pain, intestinal obstruction, volvulus, and intussusception. The diverticulum may contain ectopic gastric mucosa contributing to these symptoms.